Thank you very much. Thank you, Professor Tafazal and Professor Aflaq and Sheikh Zayed Hospital for inviting me at your conference. It is a great venue and great environment. My topic is Sjogren syndrome, assessment and its management. Sjogren syndrome is, in our practice, generally is something we tend to see fairly frequently. Often it is misdiagnosed or misclassified as other diseases like rheumatoid or SLE. And overall in the rheumatology community worldwide, it has not received that kind of attention as rheumatoid arthritis has received, or even to that extent diseases like scleroderma have received, in terms in that large multi-center clinical trials have happened. But nevertheless, people are slowly waking up and recognizing that this too needs to be addressed, and there are some advances which I'll mention as I go along. So it is a condition of lacrimal and salivary gland inflammation, characterized by dry eye and dry mouth and enlarged glands. Dry eye and dry mouth are fairly common symptoms in general practice. Not everybody has that, but somebody, the threshold in ophthalmology practice or in oral medicine or dentistry is there to screen for Sjogren syndrome if the condition or characteristic findings occur. The other cardinal symptoms are fatigue and musculoskeletal symptoms like arthralgias or even arthritis, sometimes cutaneous manifestations like rashes or vasculitis, and then major organ involvement in lung, liver, kidneys, or CNS. And there is an association of increased risk of non-Hodgkin lymphoma. There are two types, primary and secondary. Secondary it is associated with other autoimmune disease, so it's an overlap of, it coexists with features of Zika, dry eye, dry mouth, coexist with rheumatoid, lupus, scleroderma, and so on. And primary is you have nothing else, just primary Sjogren syndrome. So characterized as, again, by dry eye and dry mouth, fatigue and pain. These are three main symptoms. And 30 to 40% will have some other extraglandular manifestations. Most of them, fortunately, tend to be mild to moderate. The risk of B-cell lymphoma is 5 to 7 times increased in general as compared to general population. Previous studies had estimated this risk as high as 15 to 20 times, but recent meta-analysis bring it down to 5 times, which is still significantly high. The incidence is about almost 7 per 100,000 person years, and prevalence is 60 cases per 100,000 in general population. This is, again, a meta-analysis, involves Asian populations as well. The principal symptoms are in multi-system disease, so it can affect, patients may have constitutional symptoms like fever and night sweats and weight loss in the absence of any other reason, glandular enlargement, palpable parotid, submandibular or lacrimal glands or swollen, CNS, lungs, and as I mentioned, lymphadenopathy may occur in about 9-10%, 5% may have renal involvement, arthritis is about up to 40%, and a minority may have peripheral neuropathy or vasculitis and rashes. Now, the important first key message is who are at risk of developing of lymphoma and require surveillance in primary Sjogren's. So those cases who come and again with recurrent swelling of parotid glands, or on clinical examination they have splenomegaly, lymphadenopathy, purpura, ES disease activity score of 5, I will explain that as in coming slides, presence of rheumatoid factor, cryoglobulinemia, again a high risk group, low C4 complement levels persistently, lower CD4 lymphocytes, presence of on biopsy. Now these are the last three criteria, are basically biopsy features. Presence of centers, focus score of more than 3, I'm going to explain that, and on mutations of the TNF alpha induced protein 3. So these are all histological characteristics in a suspected case where the risk of lymphoma will increase. Now, the first development which has happened in the last 5-6 years is that we have a agreed classification criteria of primary Sjogren syndrome, both European, American, and world over groups, people from all the continents. So a biopsy score of focal lymphocytic sialadenitis of more than 1 and that carries a huge weightage of 3. And a presence of Rho antibodies carries the weightage of 3. And this nowadays immunological tests do give us a Rho 60 and Rho 52, both are included, but La is not a criteria. Ocular staining score of more than 5 in at least 1/5 dry eyes, objective evidence of dry eye, or a Shermer test, or evidence of hyposalivation flow rate. I'm going to explain all these. So you need basically an antibody, or if biopsy is done, if no antibody is present, then you need any of the other dry eyes or objective evidence of dry mouth. So that gives you a diagnosis or classification of primary syndrome, primary Sjogren syndrome. Now, although these are classification criteria, but by and large, as it happens in real world, we use a lot. They help us in making a diagnosis as well, although these are not diagnostic criteria. The inclusion criteria are applicable to any patient with at least one of the following ocular or oral symptoms, defined as positive response to at least one of the following questions. So you ask the patient, have you had daily persistent some dry eyes for more than 3 months? Recurrent sensation of sand and gravel in the eyes? Do you use tear substitute more than 3 times a day? Have you had a feeling of dry mouth for 3 months? And frequently drink liquids to aid in swallowing of dry food? Or from this questionnaire, disease activity question. So any one question will give you this, that you have appropriate, and then you go on to this checklist, and that will help you in doing the further test and coming to your diagnosis of primary Sjogren's. And these are the exclusion criteria for this questionnaire: previous head and neck radiation, active hepatitis C, AIDS, sarcoid, amyloid, graft-versus-host disease, IgG4 disease. Now, these criteria were applied to a group of a population of different autoimmune diseases like rheumatoid, scleroderma, and SLE. And having applied these criteria, about anything from 30 to 40% of these patients were reclassified in rheumatoid population as primary Sjogren's, 18%, and secondary Sjogren's is another 20%. In SLE, secondary Sjogren's was about 20% and primary was about 30%. So there is a shift. I mean, if you just have an ANA positive and nothing else to suggest SLE, and they have objective evidence of oral or eye dryness, then maybe it's not lupus and it is Sjogren's. And similarly for scleroderma, more or less the same kind of story. And when there are 2 or more autoimmune diseases, then primary Sjogren's is again, when you have overlap,